Welcome to the Owens Recovery Science Podcast, where we dive deep into all things blood flow restriction training. I'm your show host, Johnny Owens, and whether you're a clinician, researcher, or athlete, you've come to the right place. Each episode, we break down the latest research, interview leading experts, and translate complex science into practical applications. We're here to bridge the gap between laboratory findings and real-world implementation. What's up? Welcome to another Owens Recovery Science Podcast. I'm Johnny Owens here with my partner in crime, Kyle Kimbrell. It's been a minute since we've had one of these. Kyle, how's life, man?
It's good, man. We got a little heat wave on the West Coast right now.
Yeah, heat wave on the West Coast. Ben was in a blizzard and couldn't get out of Minneapolis.
Couldn't get home.
So, yeah, I know. He was going to drive home in the blizzard. But anyways, he made it back. He's across the hall. He's doing good, Kyle, in case you're worried.
Oh, I was a little worried. Not like a lot, but like a little.
Yeah. Well,
I'm mostly concerned about my March Madness bracket right now.
Yeah, I'm concerned that the Longhorns didn't freaking make it into the real deal. We're in the first four again.
Yeah, Longhorn basketball is they need Arch Manning.
Dude, Arch fixes everything. But it's been a busy season, man. That's why we haven't been able to do a lot of these podcasts. I feel like it's been like conferences nonstop and webinars nonstop. And you got Rancho Los Amigos tomorrow, right?
Yeah, that's really kind of cool. They're actually going to start doing. They're looking at doing BFR in their inpatient.
That's awesome
setting, which is neat. So I'm excited to go down there and talk to them and
then we have
what we can do to help.
NFL PFATs in 2 weeks out in sunny Arizona. So that's going to be a blast. So anyways, our guest today is one that if you listen to our podcast, you should know. It's Stephen Ramsey, who is the POCUS with the mostest point of care ultrasound god guru. We were at CSM together. Like, oh man, he's the god of point of care ultrasound. And then John Van Eyck, who is a PT. Where are you, John? Sorry.
I work on the Navajo Indian Reservation. I'm up in Fort Defiance, which is Seotso Medical Center.
In Fort Defiance is in what state?
Oh, I'm sorry, Arizona.
It's Arizona. Okay, that's what I didn't know if it was New Mexico or Arizona. Okay.
Yeah, we're right on the line. So New Mexico is my backyard. So
cool. Well, it's a beautiful country, man. And so John's going to go over a very cool case that came up. And so we don't do enough of these like cases. And so it's kind of not 100% blood flow restriction related, although it kind of tied into maybe doing that. But really this point of care ultrasound and why we think it's so important. And so I'm going to lead off with my case from CSM. Stephen Ramsey and I are presenting together. I'm just thinking I'm crushing it, right? You know, usually you get done and everyone's like, that was amazing. Your jokes were awesome, Johnny.
Can I get a picture?
Instead, this old angry jerk like tears me a new one at the end of my talk, comes up and he's got like a little notepad and I'm like, oh, what's going on with this guy? And so I'm bringing it up because the last piece I'm going to bring up kind of ties into this podcast we're doing today. And so I use this same joke all the time where we talk about the Augustus Beer, his beer's hyperemia.
Yep.
And then 1936 in JAMA, there was a paper where they used it and they, found remarkable changes in peripheral vascular disease. And then I do this like joke of like, yeah, but when we looked at that journal, they also had cigarette ads. So I don't know if I would trust that stuff, right? And so he comes up and he's like, you mentioned that in 1936 that they had cigarette ads in the journal in JAMA, like that it was, a problem. You realize that people didn't realize cigarettes were harmful till 1944, so I'm not really sure what your point was. And I was like, to be funny, asshole. It was just to try and be funny.
Oh.
And then I said, we have this new diabetes paper, which we're going to do a podcast with Dominic Pest on, which is a badass paper. And it was published in journal Cell Metabolism, which has an impact factor of 34. And I said, just for, reference here, or PTJ has an impact factor of like 4 or whatever it is,
Yeah.
And he got up after, and his thing he said on that was he's never been so offended in his life that I put down our PT journal compared it to cell metabolism. I was like, dude, if you were at my talk last year or I had the penis slide with the tourniquet on it, you would have been way more offended.
Yeah.
But lastly, and then I'm going to shut up and let you guys cook. We do the slides because I was having to do the safety thing of like, okay, we looked at in the military, does this potentially cause clots? And in all these healthy, elderly, and yada, 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 acute chronic trials, we didn't see signs of clots with blood flow restriction. But I said, the one thing that wasn't looked at was post-surgical. So my first randomized trial I did with the Department of Defense was we made sure that when we were doing this trial, we just were monitoring for clots. Not that I was saying we were going to cause clots. It's just our primary aim was strength and hypertrophy, but we also, like along the way, just looked for clots. And there were none. And I said, we saw, on duplex ultrasound scan, there were no signs of clots. And so he tore into me that I was putting service members in harm's way because I was trying to do a study that might potentially cause clots. So anyways, enough of this. He obviously it still drives me crazy.
That goes back to the PTJ impact factor of 4 because old boy doesn't understand there's inclusion. And
my wife was loving it because she's like, "Oh, you don't get enough people that don't love you." So she was just like, "I love this." But that goes into we were looking for clots, and I'm going to just let you guys roll into this case y'all are going to present. So, Stephen, give us a little quick hit on your bio and John as well. And then we're going to go into your course, Stephen, why you did the course, and then let's just roll into this case.
Well, yeah, let me add to that. As somebody sitting on the stage, I found it very entertaining because we didn't have anything to say about my talk at all. And I'm talking about novel ultrasound things. He didn't say a word about.
You and Al are just sitting there laughing. I was looking like, you don't have any problems with these guys? It's all me.
Great.
All me. Yeah.
Well, yeah. So I'm Stephen. I practice in Atlanta. I practice in the critical care environment, but I've been, probably more importantly and more relevant, been doing point of care ultrasound education for now going on 4 years, and I've been using it clinically for a little bit longer than that. So, I think the biggest thing is we got connected for the very kind of things you're talking about. Can we identify the presence or absence of DVT was the first question that we asked. And knowing that we can use ultrasound as PTs and knowing that we can see that reliably, I think that kind of spun into these courses that now are musculoskeletal, cardiac, pulmonary, vascular. There's a lot of really cool stuff there and a lot of people that are getting a lot of benefit. So, which brings us to John. So John took one of my courses here recently. And John, introduce yourself.
Hi again, I'm John Van Eyck. I am a physical therapist, and I actually practice solely in the emergency department. Have a diverse background, but have been in the ED for some time, and in the last, it's almost 2 years now, have been in fully embedded. And so, we're in a rural setting, and we have about 40,000 visits per year to our hospital, being a 52-bed hospital, just to the ED, 40,000 in the ED. And so we see a lot of orthopedic musculoskeletal injuries, and, we can't order MRIs emergently unless it's, we think it's a brain bleed or something else more serious. And so, it's not an option sometimes to do imaging for, musculoskeletal injuries. And so I just wanted to be able to find a way to be more accurate in my diagnosing. Saw Stephen's course and decided to take it. Glad I did. And I took it actually last summer, so in Melbourne.
That's right. That's a long hike from Arizona.
It is a long hike. It was a nice hike, though. So
Yeah, a little bit about that course. The structure is, 75% musculoskeletal, but we do touch on some of those other things. And in keeping up with you, John, I feel like you probably more than most have implemented all aspects of that. And your practice area, I think, sets you up for that because you're operating as a primary care provider in many ways and triaging people that are coming through the door, which is nice.
definitely, even the pulmonary side of it, I was covering on the floor up on MSU. Oh, probably 4 weeks after I took your course. They had the hospitalist was doing a ultrasound of the lung, and I walked in. I was like, "Oh, you got a nice lung slide there." And he looked at me like, "Why would you know?" I'm like, "We do diagnostic ultrasound. Thanks for asking." So it
That's
was
awesome.
kind of a nice moment.
Yeah.
That's what I really love about Steven's course is most people are it's just MSK that PTs are getting, when they're looking at these ultrasound courses, but to have, where we are screening the vasculature and you can look at cardiac or pulmonary, even if that's not your flavor, it's really cool to know that. And then someone like you, John, you're like a well-rounded ultrasound user now, it sounds like. Do you like on a typical day or week, how much do you think you're breaking out the ultrasound and doing stuff?
I typically break it out almost every day. The only exceptions if we're just like slammed crazy, and then even if I was slammed and I felt like there was like a great reason to get it out, then I would do it. But I do 2 to 3 a day at least. And well, I see about 8 to 10 patients a day, so that's a pretty good percentage actually.
Yeah. Do you mind sharing what system you use?
Oh boy, that one I should have grabbed the name of the.
Was it like a big GE one, or using more like an iPad, smaller?
No. We're actually using one of the big ones.
Big ones,
It's a
okay.
portable, but it's a computer-based one.
Yeah.
I know. Shoot, I can't think of the name of it. We actually just got a brand new one that is just like really nice because it's got AI and everything. I'm still trying to
Yeah.
learn that one. I'm more comfortable actually with the older model just because that's what I'm familiar with. But
Yeah.
I started playing more with the bigger, nicer one. It's in the main. Our ER is divided into fast track and primary or main, and so the traumas come into the main, and we see more of the urgent care injuries in fast track. But I work in all settings. We also have an OBS and a rapid triage assessment area. And I'll work in all of those. And I do ultrasounds in all of them as well. So,
Very cool. Are you billing for that?
not yet. Well, I mean, yes, I am in a sense. I mean, I just build it into my eval time, and that works really nicely. I probably should. Steve and I actually talked about this a couple months ago, and I just haven't tried to see if they'd pay it. But I know the codes now, and would be curious to see if it would get reimbursed. And it's just it's just got to be a trial and error thing.
Are you just billing the government primarily?
No, actually, we bill insurance if they have it.
Insurance, okay.
And then if they don't, it kind of goes into, funding through the IHS, which is nice because we can treat everybody the same. So it doesn't really matter, what your insurance is coming in.
Because when I was in the DOD, we would bill the DOD, and they're like, they don't really pay anything. It's just for fun. So I would put in I would make myself look like the most productive dude in the world because I would throw everything in there. So 10 manipulations, doing all sorts of things. Diathermy.
Yeah.
It was all in there.
That's funny.
So you guys want to talk about this case and how it came around?
Yeah. Do you want me to start, Stephen, or do you want to go? You want me to go?
No, yeah, please go ahead, and I'll fill in with the sensitivity, specificity side of the ultrasound. But you talk about your case.
Yeah, I think it's interesting because you were talking about blood flow restriction, and I don't do blood flow restriction in the ED, but this is a blood flow restriction case.
Yeah.
I had this lady came in, and she'd had an injury about 5 days earlier. It was a car accident, a minor one, very minor one, and she came into the ED for knee pain. I had assumed, classical step on the brake, hit a rut and get a twist through the knee and have a meniscus injury. So I decided to do an ultrasound. In no way did I have any suspicion of anything but maybe osteochondral type of injury or a meniscal injury. And she actually couldn't stand on the leg because she was in so much pain. She also had some pain that was similar to, radicular symptoms. And she had some history of back pain. So I wasn't again, concerned about anything nefarious here. I thought it was going to be a straightforward case. Tried getting her out of the wheelchair and onto the table, and she's like, "Look, I just can't. I can't get into that position," because I was trying to get her prone. Because she was complaining of posterior knee pain, so I was thinking maybe a Baker's cyst because it was posterior medial. And just decided, okay, look, I'm used to doing everything different. I took dry needling. I don't dry needle in any of the positions they tell you to because you're in the ER. You can't. Everything you do is different. Sometimes even manips are different. So I kind of had her in a semi-reclined position over the table and did the ultrasound. Started, where it was just easiest, which was the posterior portion of the knee, and put it on there. And I have to give kudos to Steven on this. He taught us in the course. Always check out the neurovascular bundle. Just it's right there. Check it out. Just make sure you always check it. And so I stuck the ultrasound head on there, and boom, the neurovascular bundle jumped up first and was huge. And I was like, Tried to compress it, wouldn't compress. Had her change position, wouldn't compress, and called the doc and said, "Hey, can you come in here and check out this knee? I think she's got DVT." And this is a credit to our clinicians, or providers I work with. They trust PT, very much. And instead of saying, "Well, let me look at it," she's like, "Okay, I'm going to order an ultrasound scan. There's no need for me to see it. If you think there's a DVT there, there's probably a DVT there." And so she got the DVT, the ultrasound official, and came back, and sure enough, she had a big old clot. And again, her Wells criteria, I actually ran it again this morning to make sure I figured it right. It was -1. So there's no reason to suspect this. It didn't look like it at all. There wasn't even any swelling. It was just the last thing I was concerned about. The only criteria that was a positive was the knee pain, posterior knee pain. And so it was pretty benign. So she was thankful. The provider came in, was very grateful. And so now when I asked for a ultrasound, official, just to rule out suspicion of a DVT, no one argues with me on it, which is nice. So, but it was a great.
And hopefully, you don't have to do that too often.
What's that?
So then, hopefully, you don't have to do that too often.
No, she's the only one I found so far. So, yeah. So.
Yeah, but you talk about, John, how, you placed the probe on and we're already suspicious. I think that one of the things I hear most often is we have such limited time that we don't really have time to implement ultrasound in addition to all the other things we do. How quickly were you like, man, I'm concerned?
Oh, man, I knew that if there was a Baker's cyst, I would see that in seconds. So Baker's cysts are so easy to find, especially if they're large. And if they're really, really painful, they're usually large. So those are bam, right in front of your face. Takes me, I gotta go get the machine, set the patient up, turn the machine on, put the ultrasound gel on, throw the probe on, 2 minutes, and then, the patient was her neurovascular bundle was easy to find, so I didn't have to go searching. Sometimes if you have a more well-nourished patient, it can be harder to find those things. Yeah,
Yeah,
obese
yeah,
patients. Those are
yeah,
harder to
yeah, yeah,
find. I always love it
yeah.
when I get to do an ultrasound on somebody who's slender. It's like, oh, this is gonna be easy. Um, but yeah, I mean, finding that literally, honestly, within 30 seconds of the probe on there, I found the DVT. So, or evidence
Awesome.
of the DVT. Yeah.
Yeah, and I want to just real quickly just talk a little bit about the kind of the statistics, sensitivity, and specificity of this. And this is what we talk about in the course. When we hear ultrasound for DVT, there's different tiers to this, right? There's the complete duplex ultrasound. Johnny, maybe you guys did this in your study, but this is
Hmm.
compression from the groin to the ankle with Doppler, spectral and color Doppler. And that's what, when the physicians order this, that's probably what they're ordering. But there's these kind of lower tiered ultrasound exams that are called limited exams. And what we talk a lot about in the course is 3-point compressibility and 2-point compression ultrasound. So that's just compressing around the groin, the saphenofemoral junction, and around the popliteal. That's the 2-point. The interesting thing about that is you would imagine you would lose a lot of the predictive power, the diagnostic power with that, and you really don't. The sensitivity and specificity is still above 90% for both. The false negative rate is really low. The only argument is about 5, maybe to 7% of DVTs are in that mid-femoral between the knee and the hip. And so maybe you lose out on that, but how much time would it actually add to throw that additional compression site in? We're
Hmm.
still talking about a 2 to 5 minute exam in total, just compressing those. So just for the listeners, I mean, you're taking an ultrasound probe, putting it transverse across the vessel, pushing down until you see the vein collapse. If it doesn't collapse, then you're suspicious that there's a DVT. So it's a really easy exam. I think that it's going to provide a lot of utility for anybody in the rehab setting going forward, post-op or not, for your
Yeah.
patients.
Yeah.
Yeah. I got to comment on that for just a second because people will ask me all the time now if you could, being in the ED, what course would you recommend? I says, well, I'll recommend this course whether or not you're in the ED. Like anywhere, especially anywhere rural, but anywhere, the number one course I would recommend is ultrasound, diagnostic ultrasound, because it's going to allow us to practice at the top of our scope,
Hmm.
and it allows so much patient education. I mean, I'm sitting there educating the patient. Sometimes I'm educating the providers on what I'm looking at.
Very cool.
It's just such a
Yeah,
good.
from a safety and a screen, but then also, from tracking outcomes in the outpatient setting, it's really pretty cool to see people using it for that as well. Yeah. Um,
That's awesome. I'm glad you're doing that. And I think that we talk about across the settings. I think we talk from ED to ICU to sports. If you want one thing you can implement tomorrow for PTs, if you haven't gone to a course, you could probably find an ultrasound and put it across a vessel and start compressing and seeing if you catch people there from a DVT standpoint. So I think that's the big takeaway is it's super easy, really easy to learn, really easy to implement.
and the machines are more accessible now. We would do it in the DoD. I didn't, but a lot of our clinicians did, and we had those giant GE ones that are like $50,000. Now in the military, it's just with a little iPad and a little probe, and AI's like kicking in. So it's not like it's such a huge burden to entry anymore.
No, and honestly, the neurovascular bundle looking for DVTs is one of the easier aspects of it to learn. I mean,
Yeah.
trying to get in and learn all the anatomy and trying to figure out, what layer of the quad you're looking at or the MCL you're looking at. It takes a little bit of time, but if you learn the neurovascular bundles then and be able how to track them, it's pretty simple,
Yeah.
especially if there's something wrong.
Yeah.
That's pretty cool because that's part of the skill that you could learn, like that first course, right, Stephen? I mean, you just a lot of times the hard thing about weekend courses is you learn all this stuff and then you go back and you're like, a lot of this I can't really apply because I'm just not good at it yet for whatever
Yeah.
reason, especially if you think of like manual techniques and things like that where everybody just ends up being a guinea pig. But with this, at least you take home that skill, that initial skill, and there's others that you can kind of keep working on through mentorship and things like that to get better at to where, you continue to sort of level up, if you will.
I think that's a reason why that was our first introduction as a team with ORS. Is this something that would be a reasonable thing for a therapist to do? And the answer is yes. It's really easy. I do want to touch on, I mean, I think it's nice to have this conversation. I also think that it's important still to talk about the barriers that exist. Again, the sensitivity and specificity is really high. As I mentioned, that you could, if you just compress the groin and the posterior knee, you could miss those in the middle of the femur, basically mid-femoral, and you could kind of miss below knee DVTs. But if you follow any management of VT in general, not a lot of places are actually treating below knee DVTs. Mm-hmm. The risk of propagation is lower, and the incident rate is lower. It's about 25% of all DVTs are below knee, and only about 10% of those actually propagate. Only about 2% of those turn into PEs, which is really what we're talking about trying to prevent. The DVT is not going to kill you, right? The PE is. Right. And if John didn't do that scan, and maybe he just did his manual techniques and didn't catch that, then it might have gone unnoticed and then not treated, and then, obviously could have had a really bad outcome. So.
And that's with doing a screen that's supposed to help you pick up.
Yeah,
exactly.
That's what I was going to say. You did everything right.
You did everything right, above and beyond what I think probably a lot of them do.
That lady, if she would have been in my hands, I would have been like, "Come on, let's bend it."
Man. 10 minutes later.
Yeah, I got a bill for this.
So let's say, let's propose the scenario that you did that and didn't see a DVT. So I think, especially for the low to intermediate risk, the kind of conventional wisdom would be, if I'm a clinician and I screen it, I think there's low risk to intermediate risk. What the research says is actually we should repeat that every 5 to 7 days. So that's just for the clinician out there that's saying, well, I thought this patient was, low to moderate risk. I didn't see a DVT, or I wasn't confident. There's no harm in repeating that kind of longitudinally over the course of a week or two, too, is just to rule it out. That's another part to implement.
Cool. John, are you using it also like to look for any bone abnormality, fracture, or things like that, tendon?
Yeah. I mean, if there's two circumstances. Well, I use any chance I get. You don't have to give me a big excuse to use it, but like if I can't figure out what's wrong with the knee, I'm looking at it going, I just have no idea. I'm going to get that ultrasound out and try and figure it out. If I really believe I know what's wrong, I want to show the patient what's wrong, I want to show the doctor what's wrong, I get it out. I mean, I've had 2 cases with fractures that were really interesting. One was a couple weeks ago, was a growth plate issue, and we suspected it, but for whatever reason the X-ray wasn't dropping, and so we were just not getting the pictures down, and so I was like, let me just grab the ultrasound. And so I'm in there, called the doc in, and I was like, hey, check this out. And we were able to see before the X-ray that there was a large fracture at the growth plate, right at the the tibial tuberosity. It had popped up, and so it was sitting up like this. And what was really amazing about this is you could see the gap was just really wide, and just a lot of anechoic signal coming out of that fracture. And what was also interesting about it is I could find the patellar tendon, but it was on slack, and I couldn't get it to contract because as it pulled up,
because it lifted up
the patella tendon in slack. That was an extremely cool case, and it was neat to see it and then get the X-ray and go, well, yeah, that just matches what we saw in the ultrasound. And it was neat that the doc was standing there beside me to be able to see it as well. I mean, I found it, then she saw it, and then we confirmed it. It was a neat case. And then ortho, this gets cooler. Ortho came down. He actually came back in, and he was off, and he had not seen the ultrasound, so I was able to pull the ultrasounds up to show him, and he was pretty amazed too, because he'd not ever seen it used diagnostically like that. So, and he's a great orthopedic doc. He just doesn't use ultrasound.
A lot less radiation as well. Skip that X-ray.
Yeah, he's interested now though. I'll get him to take your course.
Yeah, I bet.
Imagine.
Yeah.
John, I I got a question for you, John. I know you were well respected prior to using ultrasound. Do you feel like using ultrasound has changed your credibility amongst
Yeah.
the interdisciplinary team?
Yeah, yeah. I mean, they, in fact, when I grab the ultrasound, if they have time, sometimes they'll come in with me. But yeah, they do. And then it's neat too, because we just have a new employee. She just started. She's a doc, was at Loma Linda, I believe. Anyway, her residency was in ultrasound, and so I'm starting to get to work with her a little bit, and that's exciting. So the two of us on board together really make us a strong team in the ED because she ultrasounds just about everything, but I do a little more musculoskeletal than she does. So,
And
but
you're like a lot of people I've talked to who do it, or the ones who do it and really find it interesting and start picking up things. They do it a lot. And talking with Steven, it's like you need to really practice a lot with this to get good at it. That's why there's mentorship things and stuff like that. So you're kind of like the perfect PT where you're like, I love this thing. And I mean, that's what I want to start being able to do is mess with this a whole lot and just measure everything. Because I think it's really cool. And like I said, it's just a few minutes. It's like no big deal. And the patients probably think it's cool.
they do, and if I have time, I can go into longer studies. So I can just show the patient everything. It
Hmm.
gives me a chance to check the entire knee. But if I have limited time, I just go after what, the area of complaint. Um, I still always, try and get behind the knee just to check it, just to make sure everything's, good back there. But it's really a handy tool. And, I use it on the shoulder, getting better with the ankle. The ankle's hard.
Is it?
But getting better on the ankle. I using it on the wrist now. This is a funny story. My daughter, I can tell this. She gave me permission. Um, she has EDS, but she is a artistic person, so she's always sculpting, painting, or doing something. And she started getting wrist pain, and so her EDS doc ordered an ultrasound, a diagnostic ultrasound. Well, there's nobody in our area that does them. I tried getting here one. And so I had to sit down with the doc. Look, I got this moral dilemma. I can't, ethical dilemma, not really moral, but ethical dilemma. I have my daughter, and I shouldn't be doing her ultrasound, but there's nobody else. And so doc came in and we did the ultrasound, and there was not a ganglion cyst as was suspected, which is nice. She actually turned out to have intersection syndrome and had inflamed tendons in that section. So was able to diagnose her correctly, and the doc did the write up without my name on it.
Yeah.
That's awesome.
Anonymous ultrasound.
Yeah. John, you got to brush off your cardiac for her just to keep screening her valves, with
Oh,
EDS.
that's a good
Yeah.
idea.
Yeah.
That's actually a really good idea because that's one area that I just want to be able to. I'm hoping with our new doc that I'll be able to practice that more because that's something I would like to learn. I mean, I learned it, but I'd like to become proficient with it. Where I feel confident with it.
Yeah. In our 2-day course, it's impossible to feel great with cardiac. I mean, that's a 3-month study in and of itself.
Yeah.
Yeah. Is that the tip of the iceberg of ultrasound hard things to do?
For me, I think so. I think because we're talking about, with MSK, obviously there's angle dependence and probe placement like has to be pretty specific. But for the heart, you have that in addition to really need a lot of quantifiable data. And so using the ultrasound to measure velocities and volumes to be able to actually get to the diagnosis is important from a cardiac standpoint. Not only do I have to put it in the right place, I have to know how to manipulate the ultrasound and then know what to look for and what's artifact versus real. I think cardiac makes it a little bit more challenging, but I just had this conversation earlier today with a teacher out at Seton Hill. The reality is where we're saying we should start as PTs is if I'm suspicious that somebody has a cardiac disease, could I put the probe on their chest and just visually assess? Is their heart dilated? Is the squeeze function normal? And that's kind of what we go over in the course some more of the qualitative side, the visual assessment, and you can actually get pretty good at that in a few weeks of practice. So, yeah.
Yeah.
Very cool stuff, fellas.
Yeah.
John,
Go ahead. I'm
you're a
sorry.
lifesaver, brother.
Well, I'm just glad I went to the course. Honestly, from a professional standpoint, again, be able to help me practice at the top of what I can do. Probably the most important course I've taken as a PT, honestly. I mean, there's other courses you can kind of just read about, learn. I do functional dry needling. That really changed my life as a therapist. But it didn't give me the ability to, look into somebody's, joint, around somebody's joint and make an early diagnosis. And so I just really think it's like so worthy of my time. In fact, it was worthy enough of my time that I decided I want to try and go for my RMSK. So we'll see.
Nice.
It's it's a good career path as well. There's not many PTs out there that have done it, so it gives you some opportunities after you even retire if you want. So
It's awesome.
And that's an important thing to be able to get. I mean, it's unique that physical therapists are able to get the RMSK, right? Because
yeah,
basically APTA, negotiated on our behalf to allow us to get the same certification that physicians get.
Yeah. Oh, it's huge because it's not just it's a credibility thing. Physicians and therapists are taking and passing this exam alongside their physician colleagues. And I would argue, and I think I'm preaching to the choir here, I would argue that we're uniquely positioned to have the RMSK. Now, the next barrier is the RDCS, the cardiac version of that I'm going to try to volunteer to sit for on our profession's behalf, and probably fail, but I'm going to still sit for that.
Yeah.
yeah,
I didn't even know that. That's badass.
that's pretty cool.
It was awesome.
Well,
Good
cool,
conversation,
fellas.
John.
Yeah, John, appreciate you. Keep doing what you do, man. I love that you're also helping out the folks in that part of the country that really deserve it. And it sounds like your hospital's really booming, but you guys are doing good stuff there. So
Yeah, great place to work. So I love
Yeah.
what I do. Feel blessed because I'm in the ER. I love it, and it gives you a chance to see patients at their worst and make them better. That's a whole nother conversation, but
yeah.
it's a good one.
Well, anytime you get cases, send them our way. We'd
Yeah,
love
sure
to
will.
even just write up a blog on it, maybe not even for publication, but I think something like this could easily be a case study that we send in to JOSPT or something.
Yeah,
So
I still want to do that on the case we just went over. So
cool. Well, congrats, man. Thanks for coming on. And I think this course is super valuable. We only would do blood flow restriction. That was like our line in the sand. And then talking with some colleagues and then talking with Steven, and it was like, man, this makes perfect sense. And this is the only other course we would ever have that's not blood flow restriction. So we have Steven's courses hosted. Steven, I think you're going to have even other sites that will have courses listed. You want to plug anything right now, or?
Yeah, I think the biggest thing we're working on, John came to a general course, and I think those are really nice if you're looking to start out with ultrasound because it gives you a little bit of everything. We've got 2 new course types coming up, which will be ultrasound for the elite athlete, so geared more towards kind of the highest level athletic population for ATs and PTs, and then there's one in the critical care space, which I'm particularly passionate about. It's where I work, so we'll have a course geared for the critical care PT or OT or any other discipline in that space. So those are some things coming out here hopefully this year that'll be nice to see.
Well, when I was at the NFL Combine NBA Combine meetings last year, the 2 hottest topics were Achilles injuries and DVTs, and so lines up perfect, man. So if you're working with basketball players or any elite athletes, there's a lot of cool stuff. I know you and I talked about, Steven, so
Yeah.
I'm excited to see what that one holds.
yeah, and I'm gonna do a little spot here for Steven. He hasn't asked me to, and nor am I getting paid to do this. But I've been to 2 ultrasound courses now because I am interested in getting my RMSK. And I will tell you that Stephen's course, especially for a first course, was just superior. Really good pace. It was a smaller class so that you could learn. The class I went to was like 30 or 40 students. We didn't even get to put the probe on patients, in each other for certain, like I didn't get to look at the hip, which is the one I wanted to look at because I was the patient. And then we ran out of time because there wasn't enough probes. There wasn't enough time. When I went to Stephen's course, excellent amount of time, excellent instruction, and I learned a lot. So, I think it's a great course to go to.
Yeah. At the NFL meetings last year, a couple of the NFL teams couldn't stop just talking about how great Stephen is. Old men don't yell at him after his talks, but no, they were saying the same thing, John. They were like, man, this course was so valuable and glad they did it. And they were in a different spot because they're like, our doctors, our team doc does a lot of this, but then, following up with them, they're really trying to do like you, John, and start applying it a lot more. Even like just baseline, looking at some baseline characteristics in their athletes so they have some tracking data if they need to look at, injuries and how they want to get back to baseline. So it's pretty cool. All right, man. I guess the love fest is over for Stephen.
We can keep it going if we need to. It's fine.
We're good, brother. Your head's almost bigger than the screen right now. So, anyways, check out our courses at owenrecoveryscience.com. We have BFR. We have Stephen's courses. We don't ever say this, but if you like the podcast, subscribe and give us a rating. If you don't like us, don't do that.
Don't hurt us.
Yeah.
If you don't like us.
Don't hurt us. But we have a lot of
Don't be
courses
mean.
coming. We have a lot more podcast and content coming and a BFR app that should be rolling out here pretty soon as well. So I guess I'm free to say that now because we're so close.
Yeah.
Maybe, Kyle. It's
Gen
only about
3.
6 months late.
I know. Gen 3 is out and rolling.
Gen 3 is out. Throwing system is making a
Throwing
lot
system is out.
of noise right now. Just had some media group somehow got a picture of an MLB pitcher with it on throwing. So lots of things. All right, John. Thanks so much, brother. Stephen.
Thank you too.
Good to see you again.
Appreciate
See you
it.
guys. Thanks,
for the
John.
time.
Thanks, guys.
All
Take
right.
care.
All right. Later. Thanks for tuning in to the Owens Recovery Science Podcast. Before we go, a quick reminder that the information discussed on this show is for educational purposes only and is not intended as medical advice. Always consult with your healthcare provider before making any changes to your treatment or training regimen. For show notes and additional resources, be sure to check out owensrecoveryscience.com. And don't forget to like the show and subscribe for more evidence-based insights. Until next time, earn your deflate.